Right, guys, let's talk about intracranial regulation today. We are going to talk about seizures. Let's go ahead and get started because we got just a little bit more than usual. And of course, I love to keep these short and sweet, down and dirty. So let's get started. All right, so seizures, what are they exactly? They're actually an excess, sudden, and an abnormal electricity of the brain. It's kind of like an overstimulation that just kind of happens. And so oftentimes people get seizures and epilepsy confused, and they are not the same thing. Okay. Epilepsy is a disorder that's diagnosed where there are continued issues with seizures. Sometimes people just have one seizure and they're done. Oftentimes, babies and children, they have an infection and can have a seizure just from a high fever. So really, a seizure is not the same thing as epilepsy. So please don't get that confused. And it's just an overstimulation of the brain. It's just one of those neurons starts firing too quickly, and it results in physical demonstration of a seizure. And so there are common causes here. It could be a genetic issue. It could be trauma to the head. It could be a brain tumor. It could be some sort of metabolic disorder, drugs or toxicity. So exposure to heavy metals, doing cocaine, methamphetamines, all those can kind of stimulate the brain. And of course, I already talked about infections. I did take care one time of a baby who was born with herpes in the brain. And so they were also having seizures. So once they got the herpetic outbreak in the brain under control, the seizures actually stopped. And of course, meningitis would also be another reason why a patient might have a seizure. So a couple of different seizure types, and we're going to talk about these just so you have an awareness. Tonic-Clonic, absence, myoclonic, atonic, or akinetic, those are all called generalized seizures. And then there are also partial seizures, simple partial and a complex partial. And again, we're going to briefly talk about each of these. All right, so our tonic-clonic seizures is going to start with an aura. And what an aura is like a sensation, like you feel like something is off. Or some people describe like tunnel vision right before they have a seizure. And this is kind of your grand mal, if you will. That's what they used to be called. And so there is a tonic phase and a clonic phase. And in the tonic phase, the patient's going to be very stiff. And it's very briefly, and typically that's the point where they lose consciousness. So they start with that kind of aura or sensation or feeling that something's coming. Then they get very stiff. And then this is when they kind of fall out of their chair or fall over sideways. So falls are a big issue. Lasts very briefly before it goes into the clonic phase, which is that forceful jerking that most people associate with seizures. It's also a time of hyperventilation, and it can last about 30 seconds, but it could be longer as well. Just depends on what's happening in the body. And the recovery can take hours. Usually recovery period is also called a post-ictal phase. And typically that recovery is about double the length of the seizure. But again, this tonic-clonic is very serious because of all that heavy jerking and movement. It can take hours to kind of get through that recovery phase. Our absent seizures happen to be the hardest to detect and are most common in children. And this really looks like a daydreaming child, which is why it's so hard to diagnose. I mean, they're just kind of staring off into space. It can last a couple of seconds. They may or may not lose consciousness. They may or may not have an awareness that they even slipped into a seizure. It's just kind of like, oh, where was I for a few seconds? And unfortunately, this can happen several times a day. So these daydreaming spells, if you will, can happen and usually do happen multiple times a day. And again, like I said earlier, most common in children. We have the myoclonic and atonic or akinetic. So myoclonic, okay, this is remember our tonic-clonic, generalized jerking and stiffening of the arms and legs. It's very brief, okay? So it's very like jerking, stiff, done. And I put fall with a star beside of it. This is both for the myoclonic and the atonic. Because if you think about it, when we have stiffening of our muscles or as an atonic or akinetic and we completely lose all muscle tone, what's going to happen to our patient? They're most likely to fall. So these patients should be on safety and falls precautions absolutely 100% because they do not have control of their muscles. All right, next we have is the simple partial. And again, simple partial is going to have that aura or sensation present at first. People are conscious and aware of what's happened. What is interesting about the simple partial seizure is they only have sensory and motor symptoms, and it's a very specific area that's involved. It could be just the hand, it could be just the left arm. It's a very specific area when it comes to a simple partial. When we talk about the complex partial, this is specific to the temporal lobe. So just the sides, the temporal lobes of the brain. This patient has what's called a psychomotor seizure. And basically what happens is their behavior completely changes. The client is unaware, they have a loss of consciousness, but it is their behavior. So it's a psychomotor seizure, a behavioral seizure, and usually is very brief. Let's talk about our nursing assessments before we move into kind of our priorities and then wrap this up. So of course we want a history. Has this happened before? When did you first notice it? What did it look like? Things of that nature. So seizure history is big because remember, again, seizures are different from being diagnosed with epilepsy. So we have to get that back story, if you will. Prodromal symptoms tend to be our early symptoms. Oftentimes our patients, their body knows that it's about to happen. So there's a change in the mood. They become very irritable. They may have complaints of insomnia the night before. And then of course that aura is that kind of sensation or knowing that it's about to happen. They might have a loss of motor activity, loss of bowel and bladder function, or a loss of consciousness. And then we have something called a post-ictal phase. And in the post-ictal phase, they're very, very sleepy. Sometimes they may be confused, like what just happened to me? I don't understand what's going on. They have slurred or impaired speech or thought processes, and they often complain of a headache. And again, I have the rule of thumb that you double the length of a seizure duration to determine the post-ictal phase. But again, depending on the involvement of the brain, the post-ictal phase can be for quite some time. So let's talk about interventions. Interventions for our seizure patients is all about safety and airway. So I know we scream ABCs all the time, but this is no different. So if I have a patient that's having a seizure, I don't want to hold them down, but I do want to turn them on their side because I don't want them to vomit and aspirate or even aspirate on their own secretions. So we try, if at all possible, to get them on their side. Safety, we want to move things out of the way. We want to make sure that they have enough space to have their seizure. We never want to hold them down if they're having a tonic-clonic seizure because we can actually do more harm than good. So we have to be very, very careful about that. The other thing is a part of our kind of nursing responsibility is we need to know the time, duration, and what type of seizure. So we really want to note what time of day it was, how long it lasted, and then what type of symptoms did they exhibit. Was that stiffening with jerking? Was it just the loss of complete muscle tone where they just fell in place? So that all helps with diagnosis. In an emergency situation, especially or only really in acute care setting, because you can't really do it with a patient walking around in the community. But when they're in the hospital, you definitely want to have oxygen set up. You want to have suction set up. You want to have the side rails put up and padded for safety. And then you also want to make sure you have IV access because if they go into status epilepticus, which is a very long seizure or a seizure lasting greater than 5 minutes, you definitely want to give some sort of medication to stop that activity. And the only way to act, or the only, no, not, that's not the word I want to use. The fastest way to get something into a system is going to be through IV administration. So therefore, you always want to make sure you have an IV in place. Medications, of course, there is daily use of medications. This would be more of your epilepsy or seizure disorder, or you could have what we call PRNs or as needed, and that would be, again, either prolonged or status epilepticus. So let's talk about these medications because that's going to be the next thing on the list that you guys are like, what the heck do I need to know about seizure medications? And so basically what happens is is we want to do a depressant, a CNS depressant. So we want to suppress or depress the central nervous system because, again, remember, there's a neuron up there firing way too fast. It is doing too much, and we want to prevent it from going to other neurons. Okay, as a general rule of thumb, we want to be cautious if the patient's on anticoagulants, antipsychotics, or acetylsalic acid. Okay, so we have to be very, very, very careful of anticoagulants, aspirin, and antipsychotics. The other thing that we need to know is that calcium and acids will actually decrease the absorption of our seizure medication. So we never want to mix calcium/antacids with our seizure medications because it will change the absorption rate. So there needs to be at least 2 hours between calcium and the anti-seizure medication. The other thing is we have kind of first line drugs that we use in an emergency situation, and then we have what we call maintenance drugs. And again, this would be our more long-term seizures or epilepsy disorder. So first of all, let's talk about our first line medications. What are the first things that we're going to go to? And so our high dantoins, which are phenytoin or fosphenytoin, and I want you to look at the difference, okay? The ending of the class and the ending of the medications are TOIN. So that's how you can recognize them again. These treat partial and generalized tonic-clonic seizures. Our major side effects on all of these: depression of the CNS. Okay, seizure medications, seizures themselves are an abnormal overactivity of a neuron. If I depress the central nervous system, I depress the neuron, but then I also cause drowsiness, sleepiness, dizziness in my patient. All right, so all of these are going to have CNS depression. All of these are going to require safety because if they get up and they fall, we have a problem. So we need to ambulate them to the bathroom. They need to call for assistance. They have to have the non-skid socks on, all the things that say safety. All right, getting back to our phenytoin and our fosphenytoin, this also comes with gingival or gingival hyperplasia, depending on where you live. This is just a swelling of the gums. The gums get very red, swollen, and may even bleed. This is a normal side effect of phenytoin, so don't let that trip you up. The other thing about phenytoin is it has a narrow therapeutic index, which means they are high risk for toxicity. There is a thin line between toxic and therapeutic. And so our therapeutic levels are 10 to 20. This is going to be your patient that they have a level of 23. That is toxicity all day long. And so we have to make sure that we monitor them, dose adjustments, but we don't do that, right? We don't dose adjust as a nurse. I will get it out. All right, so that's something that you would have to contact the physician about. The next one are our benzodiazepines. I love these. These are Pam's and Lamb's, nurses' best friends. And lorazepam and diazepam are going to be your two big ones from this classification. It's going to treat absent seizures as well as status epilepticus. Again, our major side effect going to be CNS depression. So safety, I can't share that enough, guys. Okay, that's going to stay the same no matter what. And then the antidote for the benzodiazepines happens to be flumazenil. Okay, anytime that you see an antidote come up for a drug, that is a good indication that it will probably be on your NCLEX or in a future nursing test. So make sure you remember flumazenil. Maintenance are our second line drugs. This is going to be things that we put patients on for long-term use. We have two major categories. Remember, I always tell you to remember two, but no more than four. And so I'm giving you 4 types of drugs, 2 that are first line, 2 that are maintenance or second line. Our first one are barbiturates, which happens to be phenobarbital, and barb is still in the name, so you can quickly associate barbitol with barbiturates. They're for tonic-clonic seizures and again, CNS depressant. But the other thing about phenobarbital is patients develop a tolerance level. So you would have to make adjustments as their body becomes used to it. So over time, we actually have to go up in the dosing. Therapeutic level, not totally 100% necessary to remember, but it's 15 to 40 if you're interested. And again, safety is the big thing, right? Because we have CNS depression. The last kind of second line drug that I want you to keep in your head are the aminostilbenes. And this is carbamazepine, lamotrigine, or levetiracetam, which is also Keppra for short. These are used when the others don't work. And the only reason why I bring these up is because, again, we're just memorizing in fours. We're not going to memorize more than 4 categories. And these happen to be more and more common, especially as we see resistance or tolerance to other medications. So I'm just throwing these in there. Again, a CNS depressant. So we have to think, if my patient's on carbamazepine, I should instruct them to call for help when they get out of bed because we don't want them to fall. Again, I don't think that it's overly necessary, but if you're interested, the therapeutic range of carbamazepine happens to be 3 to 14 micrograms per milliliter. All right, and that is all you need. As promised, we are done. If you found it helpful, make sure that you like, share, and comment for more, and we'll see you in the next video.